If you've ever struggled with Lyme disease or you're feeling frustrated with those outdated testing methodologies that seem to give you more questions than answers, then this episode of the Lyme Insider is for you. Hi, I'm Dr. Tom Moorcroft, and I just want you to know that Lyme disease patients and practitioners deserve accurate diagnostics and effective treatments. But navigating the medical system can feel like a losing battle, leaving you sick and tired and without answers. In today's episode, we're going to dive deep into the latest breakthroughs and advancements in Lyme disease testing with the one and only Dr. Joe Burrascano. And by the end of this episode, you're going to know exactly what steps to take in order to ensure that you're getting the very best testing available so that you can finally move forward towards recovery. And for you practitioners out there, don't worry. We are taking a deep dive into why tests all seem to come back, differently, and why you're not getting the answers you want in the first time. And we're going to offer you a solution, a suite of tests that have really been found to be super accurate. And in fact, we're going to go over the recent FDA clearance of the IGeneX Immunoblot IgG and all the future things that they're working on, because this is a revolution in tick-borne illness testing. We're going to learn how we are really changing the whole landscape of Lyme disease diagnosis and treatment. It's really like we've turned a corner. And the beautiful thing is, we had so much to talk about in this episode. It was a blast. And one of the things we did is we thought we were done. We turned off the camera, and then we realized there's so much more we wanted to talk about. So Dr. B was so nice. He spent some extra of his personal time. We turned the cameras back on and rolled. We've talked about everything from the basics of early Lyme disease diagnosis all the way through what to do in chronic Lyme disease and immune compromised patients. We also talk about some of the home testing for the patients out there that might be available if you don't have access to a Lyme provider just now. One of the most important things is to get early diagnosis and treatment for Lyme disease. And one of the most important ways to do that is through understanding what the most accurate tests available are today. And if you don't learn about these new testing methods, you could continue missing the critical diagnoses and prolonging your suffering, the suffering of your patients, while time slips away with untreated Lyme disease. And if you want to learn the latest advances in diagnosis of Lyme disease, stick with us today on this episode of the Lyme Insider. Hey, Dr. Joe Burrascano, thanks so much for joining us today. It's such an honor to have you here.
Tom, thank you for inviting me. It's always fun.
Yeah, I'm really excited. Lots of really good news on the horizon for patients who have tick-borne illness or may have and want to find out. Lots of advances with testing, and I think we're starting to see a shift, and we're actually changing not just we have better testing that people can get, but the testing is so good, it's changing the paradigm. And I think we're going to be opening access to a lot more people over the next several years and changing the way we look at Lyme disease and Lyme disease diagnosis. But before we get into that, I was hoping that you could just tell us a little bit about who you are, your backstory, kind of how, because a moment ago when we were kind of backstage, so to speak, I was like, oh, I can't imagine anyone doesn't know who Dr. Joe B is. But, like you said, there's new people coming in the field, maybe some people who just got Lyme disease and they may not know who you are. And to me, you're one of, if not the guru of the field who really was the one who was out there making a difference in people's lives and no one even knew what to do or what was wrong. So I figured it'd be good to let people know who you are before we dive into some of the advances in testing that we're here to talk about.
Well, that's exactly what happened to me. I mean, I just sort of fell into it. I opened practice in the early 1980s in a part of Long Island, New York, that had the highest case rate of Lyme in the world at the time. And I kept seeing strange patients, strange symptoms, things that didn't exactly fit, like atypical lupus, atypical rheumatoid, atypical MS, atypical dementias, pediatric problems, and so forth. And turned out that's just at the time that Willie Bergdorfer was in town and Alan McDonald did his culture work. And I kind of fell into it. And in fact, in 1 week, once Alan's culture came out, Alan McDonald developed a blood culture for Lyme. In 1 week, I called back over 70 patients who all were positive, and like the light bulb went on. So it turned out I was able to clinically define the patients, like what syndrome is Lyme disease. And with the help of his tests and some new tests being developed at the time by New York State and Stony Brook, kind of define the illness from a laboratory point of view as well. And then from that, with the help of other doctors, Bernie Berger, for example, and Russ Johnson in Minnesota, we did clinical treatment studies. And basically from that formed the basis of the kind of modern view of Lyme disease about the clinical presentations, how it's multi-system and all that, and what testing works, what testing doesn't work, that there is such a thing as seronegativity. So many times, in the past it said, you had an infection. How could you not show up on a blood test? Couldn't have it. It must be that you're imagining it or some other nonsense. But we proved that that was the case. And then no one knew how to treat it. No, it was a spirochete. Let's give 10 days of penicillin like you give for syphilis early. That didn't work. And then Bernie Berger said, why don't we try amoxicillin? So we tried amoxicillin. That seemed to work better. But then we still had people who didn't completely get better or improved and then got sick again after medicine stopped. So we tried a little bit longer period of time, and a little bit longer period of time. And then we realized there is such a thing as chronic Lyme and relapsing Lyme, and you need more treatment for it, or longer treatment or recurrent treatment. And then as time went on, people didn't exactly fit the Lyme picture, and we found about co-infections. There was an outbreak of babesiosis back then. Really an outbreak. We had people in the hospital with babesiosis. We only had one drug to treat them. That was pentamidine, which is a horrible IM injection you had to get from the CDC. It necrosed the pancreas. People developed type 1 diabetes from it. It was a known side effect. That's what we were left with. It was terrible. Then Bartonella came on the scene. So little by little, this whole thing worked out. So here I was, a primary internal medicine doctor by myself in solo practice on a little small country, office. And I was seeing people from all around the country, some even from around the world. And I'd get calls every day. Gee, I have this patient with this new thing called Lyme disease. Can you tell me what it is and how to treat it? I'm in the middle of the office. I don't have time to have lunch, let alone talk to someone on the phone several times a day. So I said, all right, I'm going to write this down. And I wrote up my guidelines. You can find them still on the internet. It started in the mid to late 80s. I started writing them. So I would get these calls. I said, just give me your address. I'll mail them to you. It was before the days of the internet. Anyway, so that's how it started. And I'm very fortunate to have really great patients who were good at telling their story and were compliant and really were great, helping me learn from them. Also great colleagues. And I remember I was asked to go to New Jersey to talk about this. So I went before a group of doctors and lay people, and I started explaining things. And doctors said, hey, I'm seeing exactly the same thing here. That was New Jersey. Then I did it again. I was in San Francisco. Paul Lavoie said, gee, I'm seeing exactly the same thing. So little by little, this network developed. And that was the beginning of the Lyme Disease Foundation with Karen Forshner and later on ILADS. And so what started in my little office, I wanted to be the primary care doctor for the town, take care of, people and their kids. It turned out to become this whole thing that became the foundation of what we call ILADS and the chronic Lyme movement and all that.
Wow. So it was like, basically you were seeing, this is just dropped in your lap, so to speak. I mean, you were on Long Island at the time though, right? So, I mean, kind of a hotbed.
Yeah. They would do surveys, they'd collect ticks and analyze them. And there are pockets where 100% of the ticks contain Borrelia. 80% was the low. 80 to 100% contained Borrelia. So, it was a country. People were going out all the time. They're getting tick bites and they were getting sick.
I think one of the things that you bring up too is like, some people don't know what they should be looking for, even some of the doctors. And we know that some people get an erythema migrans rash, and we know that only some of those erythema migrans rashes are actually the bullseye that people are looking for. So even if you do get lucky enough to get the rash, a lot of people don't know what the rash really looks like, so they're missing it. And a lot of people don't, like half the people don't get a rash. So a lot of times the clinical presentation, in my experience, has been challenging and complex. But I know one of the things that you speak a lot about now is really testing complexity and like the confusion that comes around. So like, what are some of the common misconceptions that patients and even healthcare practitioners have, about Lyme testing, and really how does this, impact diagnosis and treatment of these patients?
Well, to understand why testing is so complex, again, you need a little bit of history discussion. Back 1981, Willy Bergdorfer discovered the spirochete in a tick that they named after him, Borrelia burgdorferi, the causative agent of Lyme disease. But that was a discovery from collecting ticks. So that germ that he discovered, they named after him, came from a tick, didn't come from a human being. Turns out these germs are called Borrelia. They're very complicated. They're very complex genetics. And interestingly, they can share their genes with other Borrelia. And what that means is that there's not one Lyme germ. There are dozens and dozens of different Lyme germs. And what happened back then, again, the history lesson, they found this spirochete, this Borrelia burgdorferi in the tick. They said, good, this is the cause of Lyme disease. We're going to make a blood test based on that, and we'll be able to figure it out. They did not know at the time that the one spirochete from that one tick, never drank the blood of a human being, did not represent the kind of Lyme infections people from around the world and around America were getting. For example, the type of Lyme you might find in the upper Midwest is different from what you find in Florida. It's different from what you find in Texas and California and so forth. So that one blood test based on one species and one strain from a tick did not represent what Lyme patients really had. So if someone from upper Midwest got a blood test, all the blood tests that were developed by labs and government and NIH and CDC were based on this one tick strain. So someone from upper Midwest got a CDC blood test for Lyme. He may have Lyme or she may have Lyme, but that test did not show it. And so that came up, the whole concept of what's called seronegativity. We have Lyme, the test just didn't show it. And based on the studies done now and published, someone with clear-cut Lyme disease, that test will miss half of them, 50-50, that pickup rate. And that's where the controversy came. People would come in with what looked like Lyme and a history they had tick exposure, negative blood test. The doctor didn't know what to do. You don't have a positive blood test, you can't have Lyme, and they'd start looking for something else or blame the patient or say you're working too much or you're depressed and on and on. You've heard the stories. So the reason why testing is so bad is because it's based on the wrong germ.
Yeah. And so, and this is kind of like the so-called B31 ban or strain of that laboratory strain that you're talking about, that it hadn't fed on the human. So you're kind of like you said, the part of it is we're looking for the wrong thing. And I even remember a lot of people getting like 41 bands that are positive on these blots. And, we had, you don't have Lyme, it's all in your head. And then in 2014, we published, the first cases in the United States of Borrelia miyamotoi, which is similar, but it's totally different from Lyme disease at the same time. So there's a lot of different things that people can be exposed to. I guess the question is in your work, because you already mentioned the co-infection. So we have these people, presenting with Lyme, but we might be getting a false negative on the test that's so-called seronegative because they're, maybe they're in the wrong part of the country, so to speak. But then the other thing is, what happens when people have co-infection? Because the thing that amazes me, Joe, is we test and we create a test for, Lyme disease, and we can diagnose Lyme in a mouse or a human really well. But I've never seen a study that showed if the person or the mouse has Lyme and babesiosis, say, that we validated that either one of those tests will still work in that particular, person or animal. I mean, what's your experience been with that?
Well, that's actually not true, because while that may have been the case with the older technology tests like IFAs and ELISAs, what has come now are what are called recombinant tests. IGeneX, the lab in California, pioneered this in the Lyme world, and basically they use reagents in the test kit that are completely specific, genetically matched to the germs. And when you do a Lyme immunoblot, for example, from IGeneX, which is recombinant, there's zero crossover with any of the other tick-borne germs. Likewise, when you do a Babesia immunoblot, there's zero crossover with any of the other tick-borne germs. So that's given you specificity rates between 99 and 100% based on their studies and CDC blinded specimens. So while that has been true for big box labs, let's say, I don't want to name names, but the big box labs where you get the commercial testing done, who knows? Technology, they call it IFA, immunofluorescent antibody. That type of test in Lyme has been shown to have a false positive rate of 37%. So in other words, you can have Lyme disease and you may or may not get a positive IFA. The pickup rate's 50%, but you could also not have Lyme disease and you show positive 37% of the time. So that was the problem. But the recombinant testing, which is basically DNA-based serologies, that's gotten rid of all that.
Yeah, I mean, I think that's so important for everyone to understand. Like, I think a lot of people are like, oh, we go to these specialty labs such as IGeneX, and we're looking and saying, oh, well, they're positive when the other ones were negative. But right. There's a reason for that. And maybe they're negative when the other ones were positive, and there's a reason for that. So when we boil down, say, like if we look at a Lyme immunoblot, for the practitioners listening, one of the biggest questions I always get are, what is the sensitivity and specificity? And in my mind, that's such a complicated terminology if you really look at what those mean. And I teach on this and I'm like, damn, why do we talk like this? I always go back to positive and negative predictive value. Like if it's positive, do I know it's positive? Or if it's negative, do I know it's negative? I mean, what can you say about these newer recombinant technologies and sort of the state of the art at the moment? So I want to say so our practitioners can trust to testing and also understand how to be critical of other testing methodologies that don't rely on this, recombinant DNA, technology. But then also patients need to be aware, because a lot of times our patients are so well educated, they're educating the frontline clinicians who are seeing this, but they don't have access to this through the conventional sort of news stream, if you will.
So there are two things about the recombinant tests from IGeneX. One thing is that because they're very highly specific to the germs that they're looking for, you really don't see a false positive. I think the false positive rates, as I mentioned, are between 0 and 1% for pretty much all of them. So in other words, you get a positive, you believe it. Okay. So if you do a big box lab and an IGeneX lab and IGeneX is positive, the big box is not, you believe the IGeneX. Okay. That's black and white. But the second part of it is the recombinant tests are designed to look for groups of germs. Now, what do I mean by that? As I mentioned earlier, the Lyme germ, the Borrelia germ, there are dozens and dozens of different Borrelia that clinically can cause clinical Lyme disease, not just Burgdorferi, but others. You mentioned Miyamoto as a kind of a different group, but it's the same idea. So what the immunoblots do is they're very specific for the Borrelia, let's say a Borrelia immunoblot, but they're also very broad in that they'll pick up almost all the different Borrelia. So unlike the old-fashioned test looking for that one strain that came from a tick from Long Island by Willie, they call that strain B31, these immunoblots will pick up all the different strains that are known to infect humans. In fact, they've even picked up strains that don't even have names yet. And sometimes you get an immunoblot report and it'll say you have Burgdorferi or you have Guerinii, which are the different species. But it might say you have a Borrelia, but we can't tell you what species it is. If that result comes up, it doesn't mean it's a negative test. You do have a positive test. You do have evidence of some infection. But it's either a mixed infection, we have more than one species, and it just gives you too much information to sort out, or it's a different species altogether. So that's the thing about the immunoblot. It's very sensitive, not only because it's a cleaner, better test, but it's also very sensitive because it's picking up things that other tests just cannot do.
So it's actually looking for, I've always described it as looking for more. Yeah. I mean, it sounds like that's an accurate way to say it. Because if I'm looking for only B31 and you don't have reactivity to that, we're going to miss it. But when we do this broader look, and I mean, I think that's an important piece. And as you were talking about that clinically, I just had a case recently of a kid with PANS triggered by some infection. He had known tick exposure and really couldn't figure it out. And I got an immunoblot for Babesia. And what was beautiful was it wasn't Microti, it wasn't Duncani, but it was in the genus Babesia, another one that we know, but just, you can't get everything on one piece of paper. But it was able to tell me it was in that group. I knew it. And then I was able to start treatment. And clinically, it kind of made sense. I mean, I know the case is much more, as with most our people, much more complicated. Right. But in the background, I was like, what am I missing? And if I had ordered anybody else's Microti or Duncani test, I would have missed the fact that he had a different one because he didn't have those two. And I started effective treatment and within weeks turned around years of issues. And it's just like we were talking before we started that it's always good to have a few people like myself who are out there treating the kids and willing to be open to this other possibility. But if I didn't know about this technology and I didn't ask my patients to order the right test, we would have not known. And he could have been struggling, perhaps never with a diagnosis that's correct, So it's really important information, I think, to get out to people.
Especially since the illnesses are so non-specific in how they present, especially in kids. They're not acting well. They have some, learning disabilities and so forth. What is it? It could be a million things. So here, it's good to have a test that has such a high specificity you believe are positive.
Yeah, and one of the things that I often get asked too, and I'd love for you to kind of enlighten us on a bit, is when I go to, say, one of the big box labs, and most labs in general, I'm going to get this answer, and it's going to be positive or it's going to be negative. And when you look at something like IGeneX, they have positive and negative, but then they also offer this thing called indeterminate, So I was wondering if we could dive into that a little bit, like, one, what it means and why is that actually important, to the, when we're interpreting the lab testing, obviously taking into account their clinical picture and their history, in addition to that.
Gets a little bit complicated.
Well, that's what we're here to do. Ask all the hard questions.
I don't want to get crazy here. Anyway, so basically what it means is that there's some reactivity going on, but not enough to be named in that specific test. So if you have a test for Lyme Borrelia and it's indeterminate, maybe you have a relapsing fever Borrelia. See? So in other words, it's a different group of Borrelia, and then you get a relapsing fever immunoblot. So if I see someone who's symptomatic in a way that could be a tick-borne disease and they have an indeterminate on the test, you do one of two things. Either, number one, you look for something similar, like I said, relapsing fever Borrelia versus Lyme Borrelia. And number two, what you do is you wait a bit and you repeat the test, because people's immune system response evolves over time. And sometimes waiting a little bit, it'll start to show a positive when otherwise it did not. Now, the complicated part is if you go to a big box lab and get an indeterminate, that's a whole different thing, because their standards for positive, indeterminate, and negative are statistical results. In other words, they say, all right, a positive has to be 3 standard deviations above the mean, and an indeterminate is 2 standard deviations. Different lab might say a positive is 2 standard deviations. So you're working on statistics. 2 standard deviations means maybe an 85%, maybe 90% the most sensitivity or specificity, and 3 standard deviations might bring up to 95 or 98%. So you're working with statistics rather than real genetic results based on tests and cultures and so forth. So if you're talking about an immunoblot, indeterminate is a clue that you should not ignore. If you're talking about a big box lab, indeterminate doesn't really give you any information at that point.
Yeah. Well, it's interesting. One of the questions that I had, and I think it kind of just popped up, is we talk a lot about indirect and direct testing methodologies, and that they mean different things. But it almost sounds like this is sort of the immunoblots are almost like a direct indirect test, or at least they're kind of morphing to getting this next level of accuracy by not relying on just like one thing and then statistics, but we're actually, are we actually including, well, maybe we should back up and maybe define what an indirect and a direct test is, but maybe you could tell us where the immunoblot really falls on that sort of spectrum.
Yeah, an indirect test doesn't measure or detect the presence of the germ itself. It looks for the body's response to it. So an immunoblot, like an ELISA, like an IFA, like a Western blot, they measure your body's antibodies. The thinking is that you have an infection. If you have an intact immune system, you make antibodies against it. Then this test will pick that up. Problem is there's a lot of background antibody in our system from normal germs that live in our mouth and our intestinal tract, on our skin even. And you have to have a test that is able to filter all that background noise out. And immunoblot does that. A direct test, on the other hand, measures the presence or detects the presence of the germ itself or parts of the germ. And a perfect example of that is a PCR test, a polymerase chain reaction. It looks for fragments of DNA that might have come from that germ. DNA testing, like a PCR, is very insensitive in the blood, at least for tick-borne diseases, because, number one, there are very few of these in the blood at any one time. And number two, the blood contains different chemicals that inhibit the PCR process in the lab. We have heparin in our blood. Heparin interferes with DNA PCR. We have human DNA circulating around. That interferes with it. So many different things make a human PCR for the blood very inaccurate or very insensitive, let me put it that way. So the direct testing like that is not a first line test because you don't, in other words, you get a positive, you believe it. A negative could be anything. In fact, Ed Reichwart and his colleagues did a study on sensitivity to PCR and Bartonella, and they found it picked up 6% of the cases. In other words, it had a 94% false negative. So it's kind of useless, you know?
Wow.
So the other thing about PCR, and I'm going to just mention it because people always say that, is people say, well, even if you have a positive PCR, it could mean that it's an old infection and just the DNA lingers afterwards. Because after all, you can do DNA tests on mummies and find things, and fossil records and so forth.
Right.
But the thing is, our bloodstream contains enzymes. They call them DNases, that break down DNA. So DNA in the blood doesn't live more than a few days. DNA in tissues, because there's no blood there, of course it can live dozens or hundreds of years. So a blood PCR, if it's positive, you believe it was an infection at the time the blood was drawn. Tissue PCR or biopsy, you don't really know. So that's a problem with that kind of a direct test. So what did IGeneX do to get around that? They combined a culture with a very carefully designed PCR test. So they take a sample of the blood, they filter out all these inhibitors, they put it in a culture for 2 weeks, and then they do a special PCR on it, one that was designed specifically for this kind of a culture. And not only are they picking up a very high rate of infection that was orders of magnitude more sensitive than the standard PCR, but they're finding very strange things. You talk about your patient with Babesia. There's a case, and I talk about this a lot, a young woman who had been diagnosed with chronic fatigue syndrome because she was chronically ill and no one could figure it out. None of the tests from anyone figured it out, showed any results that made sense. Her blood was tested by this culture. We call it a culture-enhanced PCR, CE-PCR. And they found a parasite called Colpodella. I said, what is that? We had to go look it up.
What the hell is that? Yeah.
Colpodella is a single-cell organism that lives in ponds and in soil. And somehow she picked it up. The world literature, searched the world literature. Only 2 cases of human infection in the worldwide literature of an infection with this. So here they found she had Colpodella. Of course, they didn't believe it. So the lab went and they repeated the sample. And again, it was positive for Colpodella. And they know because they sent it to an outside lab for DNA sequencing, and both times sequenced positive for Colpodella. So here she had this 2 out of a whole world of billions of people infection. Nobody knew what it was or how to treat it, but because it's in the same family as malaria, she was treated with anti-malarial drugs, and she recovered. Almost 2 years in chronic fatigue went away in a matter of weeks from this because she had that test. You see, so that's the beauty of doing a direct test if it's a culture like that will pick up the living organism. Another direct test, which is useful, is a FISH test, fluorescent in situ hybridization. And that's actually a blood test where they take a drop of blood and put it on a glass slide and look under the microscope. Now, if you did that for Babesia or Bartonella using a standard blood stain, you'd have to have a very high rate of infection to pick it up. But what they do with the FISH in IGeneX is instead of a standard stain, they have a fluorescent stain that binds specifically to the RNA, the genetic material of the organism. So it's very, very specific. In fact, the specificity for Bartonella has been shown to be 100%. And it has a sensitivity 10 to 100 times more than a standard blood smear. So that's a direct test where if you get a blood test and you find it positive, you believe it. Number one, because you're looking at the blood directly under a microscope. The other thing, which is very subtle, they are staining RNA, not DNA. RNA has a half-life of minutes in the bloodstream. So if it was a dead organism, you wouldn't pick it up. So in this case, a positive FISH, unlike a positive PCR, does indeed mean the infection was present the time you took the blood test.
I mean, that's so important. And I think the big testing in this arena becomes like, or in this field becomes so complicated and confusing. Everybody's got a better mousetrap, so to speak. But I think you did a really nice way of, overview of like the different pieces and where they're important and why they're important. One of the things that a lot of people I think say about IGeneX is like, well, they're always positive. And I'm like, well, actually what I personally found is that I get immunoblots that look like they're accurate because clinically they make sense. And at times they even are negative when I think they would be positive. But then I get another answer as part of the workup and part of the immunoblot panels that guides me somewhere else. Like I even said with this kiddo. So I found them to be much more clinically useful now than even 5 and 10 years ago because the accuracy has gone through the ceiling. But even though I just said that and you just said that, there's a ton of people out there who are going to say, well, no, these specialty labs are not the most accurate. They're just making stuff up. I recently heard about, the work, the FDA clearance of the Lyme IgG immunoblot, or at least the reagents behind it. And I think a lot of people are going to, did a quick video about it. The importance of, considering FDA clearance and stuff and called it FDA approved. So, I even used the wrong terminology, I think, but I think it's really important for us to kind of, because like when I was listening to you just then, it's like what IGeneX does to find out what's really going on and to confirm things that one makes sense and also things that don't make sense is above and beyond what I've heard anybody else really doing. But I mean, I feel, could you kind of give us a little background on what's going on recently with the FDA and what that really means? Because I think that this will shed a lot of light on the difference between, say, the big box labs and IGeneX, and even IGeneX and some of the other sort of specialty labs out there.
Well, yeah. If you develop a test as a lab, like IGeneX developed the Immunoblot, that's called a laboratory developed test. And that lab can be run, that test can be run in that lab, but only in that lab. Now, if IGeneX opens a sister lab down the block, both labs can do it because it's IGeneX. But you can't say to a hospital, here's my test tubes, you can do our Immunoblot in your hospital, because it's a laboratory developed test that lab was certified by CLIA, by the state, by all the different certification agencies, but hospital XYZ down the block was not. So the way you get around that is by the clearance of FDA. What FDA clearance means is that IGeneX actually did develop a test kit with the test tubes and whatever it is, that they can send or sell to another lab or another hospital or even, a clinic. And then because it's an FDA cleared test, that lab or clinic or hospital can run that FDA approved Lyme IGeneX Immunoblot. So number one, that means that this fantastic technology might be available down the block. And, a lot of hospitals don't like to send lab specimens to a competing lab. Let's say your lab is a state lab and they do their own Lyme testing. Well, they're not going to not do that and send it to a competitor lab and have to spend money. But they might say, we want to get a higher level test. Let's get, instead of this kit from Germany, which we're using now, we're going to get this kit from IGeneX, which is a much, much better test. Now, what is the difference? Number one, as I said, it's much, much more sensitive. Number two, it's much more specific. Number three, it does multiple species. Okay. Now, there's more to it than that. If people know about Western blots and immunoblots and what are called the bands, how you identify what they are, when the government got together in the famous Dearborn Conference in 1991, they set standards for how to interpret a Lyme Western blot. And a Western blot shows different bands or different results on their test strip. And they're given numbers. And there's number 18 and 20 and 21 and 23 and all the numbers up and down. And these numbers represent protein antigens from the germ, okay? And the body's reacting to it. They, at the time, were also competing with labs and doctors who were developing the Lyme vaccine. The Lyme vaccine was based on the proteins number 31 and 34. So in their strange wisdom, the Dearborn Conference says, when we do a CDC or an FDA Western blot, we're not going to include those bands because what if you ever got a vaccine, you get a false positive on it? Well, that's ridiculous because it never worked out, because even if you got a vaccine, the other bands showed up anyway. It's a long story about that. But the bottom line is bands 31 and 34 on a Western blot or an immunoblot are very, very important bands, accurate, specific, sensitive, and so forth. But because this rule came from the government, anytime you go to a big box lab, a commercial lab, a hospital lab, anywhere in America, and Europe too, by the way, you're going to get a kit that does not include those bands. And that's really bad because those are very important, very specific bands. So the big news about IGeneX is that their Immunoblot test kit, which is FDA cleared and can be done by the big box labs does include 31 and 34. It's the only government approved test in the world that has that qualification. And there's more. In the same conference in Dearborn, they said, well, we're going to put 10 different numbers, these bands, on a Western blot. And we're going to have you have to have 5 out of these 10 to be called positive. The problem is other germs make proteins and antigens, and they cross-react with Lyme germs. Well, you had said before, band 41. That's a band of a flagellum. A lot of germs have flagella. So if you use a band 41 on your Western blot and call it a positive band, it's not very specific. So when CDC and the government people said you need to have 5 out of 10 bands, their specifications of which bands included bands that are not specific for Lyme, and they didn't even include 31 and 34, which are specific for Lyme. So it's pretty much of a mess. What IGeneX had proved to the FDA and how they got their clearance is that you don't need 5 out of 10 bands. In fact, we have, how many? I wrote it down. They have 31 bands on their blot, but all you need is 2 positives, because that's how sensitive the thing is. 2 bands, 1 from each different group. And the different groups, like the bands of 31, 34, 30, 23, whatever. But all you need are 2 bands, and that will include 31 and 39. So it's so much better at picking up all these other different infections besides the tick, Borrelia burgdorferi from the island off of New York. It's all the different ones around the country and around the world. So the FDA clearance is huge. Number one, it allows us to get this high-quality test pretty much anywhere that the hospitals are willing to incorporate that into their protocols. Number 2, it includes multiple species, which the other tests do not. They said you'd have to have, I think, 11 different Western blots to do one immunoblot, and even that wouldn't be as accurate. And number 3, it's got band reading criteria, which makes sense. It includes 31 and 34, and just 2, not 10, not 5 out of 10. So it's huge. It's revolutionary. It's huge.
I mean, yeah, that's what I'm thinking. This is like changing everything, right? I mean,
absolutely.
So the clearance actually says that an IgG immunoblot can be called positive if there's only 2 bands.
That's correct.
That are specific.
Yep.
See, so I mean, to me, this is not. I mean, how many people have you seen who they have 4 out of 5 bands on an IgG, or you know, they've got a 23 band or 39 band on an IgM, but they don't have a 41. And I'm like, well, just cough on them and repeat it in a week. And I've seen that happen, you know, and they're positive. So many people who would previously be missed, even if they did have the B31 experience, you know, so to speak, they're going to be getting picked up because we have more not relaxed criteria, but actually more accurate criteria to pick up the infection. And then, like you said, we're collecting more. I mean, I know you can't really say for sure, but I mean, is this going to change like the way we do everything? I mean, is this going to mean that this to me feels like a tidal wave of change in the Lyme world? You know, because I mean, this is one of the most
interesting thing is happening. There's enough mass of whatever you want to call it, publicity, pressure, whatever, around this country that people are starting. I think it happened after COVID became long COVID. People are now recognizing Lyme and long Lyme. And different hospital systems around the country are now opening up Lyme clinics. And these Lyme clinics are calling IGeneX to get this immunoblot kit so they can have a better test. And they can say, well, my Lyme clinic is better than yours because we have a better test. So it's now a matter of pride to have a better test and have access to IGeneX, because now they're going to have a better Lyme clinic, make better diagnoses. So now this competition using these new better tests is going to allow for better diagnosis all around. And what about these people who are chronic fatigue syndrome or chronic complainers and, oh, we have a positive test that's, you know, got a 99% specificity. You can't ignore that. If you do, the lawyer's going to come knocking on your door.
So, and part of it is, I heard that, like, I mean, FDA clearance is not something a lot of people get. One, because it's hard. And it's the number one thing. It's not even the money behind it, which I don't even know anything about, but I can assume there's time and money put into it. But just the FDA doesn't really clear a lot of stuff. I mean, if anything, they're ultra conservative, at least in my experience. So how accurate does this really I mean, because like it's kind of like mind blowing. Like one, they approved Igenics in general, just because everybody seems to that. Oh, that I've heard so many patients. They went to the ID doctor, the infectious disease doctor, and they said, "Oh, that lab is crap. They're not accurate." I'm like, here's the FDA, which is probably even more conservative than your infectious disease, your typical infectious disease doctor. And they're saying, no, actually, not only, I mean, and correct me if I'm wrong, but not only is it more accurate, but it's more accurate with less positive bands because it's so precise. Is that an accurate statement?
If you got an immunoblot from Igenics right now, without going to an FDA, lab, but if you went to Igenics directly and got an immunoblot, you see interpretation by either Igenics criteria, which is a 2-band criteria, or by CDC's 5 out of 10 band criteria. So they've been reporting this 2-band criteria now since 2017. So it's been around a long time. But now FDA has given their stamp of approval that, yes, you can believe the 2-band criteria because it's as accurate, in fact, more accurate than their comparator test, which the FDA uses as their gold standard.
Right. And so you have to prove that you're at least the same or higher, right? Or like to get the approval.
Yep.
I know I just said this before, but this is really important for everyone listening to understand. The FDA did not relax criteria. In fact, they have higher criteria, and they're saying, we're going to allow you to use less. We're going to essentially relax the criteria for positive, because at the relaxed criteria, we're getting more accurate results with known. And that's how they do it, right, Joe? I mean, they have it. Igenics has sent known samples, and they're pretty much 100% spot on accurate.
Well, the statistic was, I think, out of 200 samples looking for false positive, they got one false positive out of 200. So it's 99.5% specific. And I think the one that was a false positive was syphilis. I don't know exactly for sure, but it was something another sparky. So, I mean, 99.5%. How many tests in medicine are that accurate? Very few.
I've been talking, you can go look at all these, some of these old things I've done. I'm like, hey, well, there's that meta-analysis showing 56% sensitivity of the standard 2-tier approach.
Yeah.
But the problem is, I would always say that means out of 80 out of 200 true positive people, meaning if you took 200 people with truly had Lyme, we'd miss 88 of them.
Yeah.
Now, if I contrasted that to HIV, first of all, if you missed 88 out of 200 in HIV, the public would be freaking out. But in HIV, that's the only other testing I know that you get to that, like you miss 1 out of 200. I mean, that's insane. And when you're having one false pot, this is like it's almost, you can almost not conceive of anything more accurate. Because, there's always going to be some little ditzel that happens somewhere. I mean, that above 99% sensitivity, or specificity, is totally game changing. And, well,
I was going to say that, we talked about the bands and 5 out of 10 and 2 out of 10, but you really cannot compare to a Western blot because there's fundamental differences between a Western blot and an immunoblot. Even though they sound alike and they kind of look alike a little bit on the test paper, because an immunoblot is made from genetically created antigens. Let's say they look at Lyme, they want band 34. They take a Lyme germ and they look at all the species, not just one, but they find the Lyme germ. They look at the genetic sequence that makes band 34. They clone that, put it in E. coli. The E. coli produces specific band 34. Then it's put through chromatography and other purification steps, and then it's put on the blot. But instead of like a Western blot, they take a culture of the germ of one species, not all these 20,000 species, but one species. They culture it. They break it up with ultrasound, they sonicate it, and they spread that out using electrical charge, electrophoresis. So wherever the blots end up, wherever the dots end up, that's the Western blot. So this is totally different because it's not from a cultured lab strain. It's not a lab strain at all. It's human strains. It's not put through electrophoresis. When they get these super pure E. coli cloned proteins, they use an inkjet printer and they print it on the paper in specific spots in specific amounts. On a Western blot, which is a culture, if it's a strongly grown culture, you got a lot of bands and they're very dark. If it's a weak culture, you get a few bands and not very much. Another thing Igenics found is something people haven't heard. when they were making the Western blots years ago, you call ABC Scientific for a culture of Borrelia guerini, and that's what you can make your Western blot out of. Well, they were very smart. They looked into it and they sequenced it, and they found they actually had a contaminated mixed culture of different Borrelia. So the so-called lab standard that other labs are using to make Western blots may in fact not be pure Borrelia burgdorferi. So to get rid of all that uncertainty, they go through this crazy step of reverse engineering the genes to get exactly what they have on an immunoblot.
I mean, yeah, it's like the next level of effort to really dial it in. And people are always like, why do things cost a little bit more? I'm like, because you get what you pay for and you get that high definition.
Yeah.
I remember I recently did a blog post about it, but when you look at a Western blot, like samples, just so you guys can do it right now, do Western blot online and just look at like what it looks like, and then go grab a picture of the immunoblot at IGeneX. It's kind of like, when we grew up and we had the TV with the antenna that you had to keep moving and stuff. And you're hoping you sort of think you're on channel 3, but it might be channel, whatever, 10 or whatever. And then it's like, but you end up being able to see almost nothing, and you're squinting, thinking.
Well, look at a test pattern in that case, a snowy test pattern, right?
Yeah. And that's what it looks like. Snowy test pattern is exactly right. And then on the other side, you get this clean, pristine, super precise. And I think, Joe, you really highlighted why that actually is happening. So, one of the other questions, or one of the challenges that we always run into are, like, things like New York State and things like that. I mean, getting approval to use different tests in New York State. I'm assuming IGeneX will continue to get more FDA clearance and work in that direction, so that all these blots hopefully can be used to get this high definition testing and this more accurate testing. But I mean, does something like an FDA clearance or the stamp of approval for them help us change the minds of, just standard hospital clinicians, the IDSA, or even New York State and their criteria for approving this? I mean, and another way to answer is this kind of clearance going to open the way for more and more people to actually have access to this testing, maybe through some alternative avenues, do you think? Well,
absolutely, because, New York State has clearance for laboratory-developed tests, and a lot of labs with lab-developed tests don't go through the trouble of New York State because it's terrible. It's a terrible procedure. It's costly, time-consuming, and there's some other subtleties. So a lot of labs just don't offer their laboratory tests, or lab-developed tests in New York State. But FDA is federal. It supersedes New York. If you have an FDA-approved test, New York can't ban it. It's federally approved. So an FDA-cleared test like the IGeneX IgG immunoblot is available in New York State.
So when you go to the doctor and they say that this test isn't really all that accurate, now you can just pull out the stamp of approval and say, well, maybe you need to pay attention.
And don't forget, FDA clearance means there has to be publications. And you can, just like, a package insert for doxycycline, there's a package insert for the Lyme IgG immunoblot from IGeneX, and you could look it up. And there it is. And they give you the studies and the statistics and the results compared to, all these unknowns. So there's no arguing it. I mean, someone says, I don't believe the test. Well, do you read the literature? That's the other thing about IGeneX. I don't know of any other commercial lab in the tick-borne disease world where they publish and publish and publish and make their results, available publicly and display it the way IGeneX does. They have nothing to hide, and they're proud of their results.
Right. Well, and I think that, like, I've always heard all the data, like, oh, we missed one sample out of 100, or we missed 3 samples out of 400. And we were, when I was first getting started, like the last 10 years of testing, we were the best lab in the whole country, but everybody was still looking down on them. I'm like, well, it's Medicare approved, and Medicare pays for nothing. So clearly, if they're paying for most of the testing at IGeneX, someone said it was good, but now we're at that next level. Do you know if they're working on things like getting the IgM immunoblot approved and or some of the other testing? Or excuse me,
there are other ones
cleared?
Yeah, they're in the pipeline. Yeah.
Nice. Well, I think that's just, for me, I hear a lot of hope here, because it's really cool if you can get to a Lyme, if you're in the know and you get into the Lyme world and you get to see a doctor like, when you were practicing, Joe or myself or some of the other amazing people like the folks in our Lyme disease practitioner certification and mentorship program. But the thing is, my thing is not just getting it to the people who have access or in the know, but getting it beyond that. And that's the part where I was like, when I heard what happened, I wanted to have this conversation so people can know that this is change. This is ultimately and really already changing the landscape because of the focus on the accuracy, and then getting the FDA, working with the FDA to make sure that they're meeting those criteria. And, you think about it, it's like, it's revolutionary. You're getting more accurate results. And the FDA is saying, yes, we agree with that because we've tested the living shit out of it. And we can't find a hole in the technology. So I'm hoping to all the conventional docs out there listening, like, don't take my word for it or Joe's word for it. Look at the package insert, so to speak, as he said. Look at the data. Look at the FDA clearance, because this is the gold standard that you all are suggesting that we need to have all the time. Yet a lot of the labs that you're using don't. Or this has been, in the case of ones that maybe do at the big box, this has been shown to have a higher level of specificity than some of the things you're already using. So don't your patients deserve to have that higher level? That's what I look. I love the truth, Joe, because today what we know might change next week. Right. And I'm not I don't feel bad because I'm just doing the best I can with the best science today. But when the science changes and it's been rigorously validated, and it's not just Tom and Joe said so, but it's, hey, the FDA looked at it. And a lot of people, I think, listening I guess this is another thing, I'm curious because you've been through the ringer with this thing. I mean, you've been the sacrificial lamb for so many of us to unfortunately, and been on the whipping post. But I think a lot of, because I was talking to sort of more of our conventional colleagues who maybe, view Lyme the way more we were taught in medical school. They might be open to seeing the change. But then there's the other group too. I mentioned the people in the know, and not that anybody's not in the know, but some people have a different experience and a different exposure to knowledge. What about the people who are, say, maybe, Lyme patients or family members of Lyme patients going, hey, I don't trust the FDA. I mean, and I hear this all the time, and I know this isn't everybody's favorite question, but I think it's important to talk about it. And I was just curious. I have my own opinion, but I'm really interested in what your feeling is, kind of being on the inside of seeing what this process really means for testing.
Well, FDA clearance and approvals are for a lot of things. It's for, in this case, a blood test, but it's also for drugs. It's also for medical devices, like a blood sugar machine that's got to be FDA approved or cleared. So they have a lot of different things that they do. FDA has gotten a bad rap for maybe approving some medications or vaccines too soon before the studies are in, and that's a whole different ballgame. But when it comes to something like a blood test, like was what we're talking about, they have the data. There's 700 and something samples were tested blindly. Another 200 negatives were tested blindly. There's data there, and it's not something you can argue, really. You can argue, well, XYZ drug or XYZ vaccine was approved and then the studies came 2 years later. No, in this case, the studies of 2 years or so or more were done and the results are in and they're published and here they are. So it's a whole different category. You really can't compare the two.
Yeah, I really appreciate hearing that because, this was, it's good to know it's not a rush. And it was kind of like they went through every step of the process and the overly critical. Because sometimes I'm like, I'm amazed at things that get on the market so quick. And I have thoughts and opinions like many people do. But some of the things are so delayed by the bureaucracy of multiple extra steps that as a clinician, I'm like, you're holding back us being able to do this. And which is what I've loved about the IGeneX process is I've been able to, through one, IGeneX testing was what allowed me to get rid of the chronic fatigue and fibromyalgia diagnosis by finding out I had chronic Lyme and Babesia and get better. And I always just want to throw a quick plug in for 13 years asymptomatic after 12 years of illness, so you can get better. Yeah. I do think that people need to know that. And I think that the other thing you'll hear me say all the time, and why I'm so excited about this conversation, early diagnosis, early recognition, and early treatment, and early effective treatment is the way to prevent a lot of this for being chronic. It's kind of hard to have chronic Lyme if you never had Lyme. So
right.
if we can identify, right. So let's identify these things, and knowing that IGeneX has been able to follow an appropriate lab standard and making the in-house test, but then went the extra mile to get the FDA clearance. So it's not just those in the know or those who trust IGeneX. Now it's like the data is in. They have said, send me all the blind samples you want. We believe in our test kit so much. And they're better than everybody ever tested on the history of the planet, as far as I can tell from my read of the literature.
Yeah. And, the FDA process I find was fascinating. I wasn't involved in it. I just heard about it after the fact. But it was a give and take. It was a two-way. IGeneX would submit, and they say, I'm not so sure about that. So IGeneX said, what do you want us to do? And they said, this is what you need to do. And IGeneX did it. I said, okay, let's go to the next step. So it was a collaboration. So FDA was very strict. That's why I say sometimes these things take years to come out. Well, they say, wait, we don't believe you. We want you to go one step further. Everything they threw in front of IGeneX, they were able to overcome and accomplish to the point of getting this historic, clearance.
And the other thing that's so interesting too is there are bad raps out there, but a lot of time the scientists that I've met who are involved in these things are often really, really passionate about making sure that it's super accurate. And if you're going to make a change and include a 31 and a 34, you're going to go from 5 bands down to 2. And I can't wait to see what happens with the IgM process, because to me, this is the next one in the pipeline, I hope, because this is going to blow the doors wide open for patients, and accuracy of diagnosis and that early detection. So really excited about that. So it's just, and to know that the labs will partner. Everybody seems to think we're on different teams. We just have different roles in the game. Yeah. And to see that those two sides have been able to come together, because I always think I talk to a lot of the IDSA people, I talk to a lot of the ILADS people, and we're friends. We're all friends, because most of us, even if we have a different opinion, we want the patients to get the best out there. So to hear this story is just warms my heart in a field that doesn't often have, in a quick, heartwarming story. You got to wait years again. So one quick question before we kind of roll things together. Two things. One is I want to kind of give you the last word, but I have one last question before I do that. Is this kind of opening the door to potentially insurance companies and hospital systems being able to offer things like the highest level testing that IGeneX offers through, in a way that might be covered by insurance outright? Or is that something that might be in the pipeline down the road?
Well, sure. Insurance coverage is not up to the lab, to IGeneX who developed the test. It's up to the hospital system or big box lab that's offering the test. So if, let's say, Mount Sinai Hospital in New York is going to offer IGeneX testing, then they're going to make sure that they get reimbursed. So I'm pretty sure that if it's not happening now, it's going to happen soon, that you get coverage. Because how could insurance not cover the cost of an FDA-cleared test? I mean, I don't know the answer to that, but it boggles my mind that they would say, no, by the way, you can't. I mean, on what grounds, So I don't know. I mean, that's an open question, but I'm very anxious, as you are, to see how this plays out. One other thing I want to bring up before we go, you said you want to get rid of or diagnose Lyme early. When you look at the immunoblots, IgM, IgG together, they have a combined sensitivity of 93% in early Lyme disease on CDC's own supplied blinded samples. So CDC defined early Lyme, which is people with just an EM and no symptoms, or the very early symptoms before the EM. They picked up 93% of those cases. Never in the history of Lyme has there ever been a test that you can use with that accuracy in early Lyme. So if someone comes in the summer flu, no rash, no bite, but they might have been exposed, you have a test. Someone has a strange rash, is it ringworm or spider? I don't know what it is. You have a test. Otherwise, what are you going to do? Give antibiotics and not know, or wait a month and see if they get sick and now they're sick? So that's a game changer also that I definitely wanted to mention.
That's amazing. Yeah, I think, and I know a lot of people that I work with really love knowing the sensitivity and specificity. And I think if you look at the meta-analyses of, the two-tier testing approach, you're looking at 56% sensitivity in early Lyme. And it's like, now you just said we went from 56, which essentially is a 50-50 roll of the dice or a flip of a coin, like we were saying before. I guess flip of a coin would be more accurate. But anyway, you're now upwards over. When I was in medical school,
slided dice.
Yeah, that's all I have. It's like 1 and 1. When I was in medical school, they said the gold standard for serology, meaning antibody testing, is a sensitivity of 95% and a specificity of 95%. And they said two things. One is you would love 100%, but it's pretty much next to impossible. And pretty much no lab test on the planet does 95 and 95. But now what we're talking about is we're at 93 and 99.5.
And by the way, this FDA cleared immunoblot is a two-tiered test. Did you know that? It is a two-tier test because the immunoblot kit includes tier 1 and the blot itself is tier 2. So if you get the IGG immunoblot kit, the FDA cleared one, you're getting a two-tiered test. So that means you have a much bigger chance of getting insurance coverage for the test and insurance coverage for the treatment.
Wow. Well, the question, I'm like speechless. That's why I knew we needed to do this as soon as possible. And so everybody knows Dr. B has been pretty busy, and he went out of his way to carve out this time for us to have this chat, because this information is only a couple of weeks old, I think, at the time of recording the approval, the clearance. I want to be really careful with the term, but it's so easy to slip, right? I've said approval like 5 times in the conversation, and I think I got you to say it once.
I don't know the difference. I think one has to do with tests and one has to do with drugs or devices. I don't really know, but FDA is FDA. Let's put it that way.
Right. Well, we got IGeneX got their stamp of approval, so that's what's important. So, I kind of want to give it just like open couple of moments. It can take as long or as little as you want. Where do you see the future of Lyme for patients at this point and for practitioners? I mean, this is, to me, and obviously to you, game changing, and it's gaining a lot of momentum. But, I remember like 10 years ago, the frustration level of patients and clinicians, it's just so like, oh, we're doing our best, but we need more. We've gotten better research on herbs and medications. Now we've got FDA cleared labs. What's next? I mean, like, if you're a patient with Lyme, is there more hope now than ever? Like, what do you feel like the future is like? Because you were there at the beginning. Yeah. You've seen it all.
Well, like you said, there's momentum. Fantastic groups like Bay Area Lyme and the Cohen Foundation, they're putting money into real solid research that's getting results. And they're not just, more, IDSA kind of craziness. They're actually looking for real results for real patients, and it's paying off. And now we're getting our good testing that we've relied on, in my case, for decades from IGeneX. Now we have FDA clearance. Now the big hospitals can start to use it. This momentum is building. So I think the future is really fantastic. It's like we turned the corner suddenly. The sudden turning of the corner, where now we have the momentum, where we have good research, really much better tests. We have recognition of the better tests. We're getting recognition of, quotes, long Lyme, and we're now getting hospital-based clinics to start to see what Lyme really is and take care of patients the way they should have been cared for all along.
You were just, it was so well put. And what you reminded me of is, the quote unquote overnight success.
Yeah.
And it's like, you look at Starbucks, love them or hate them. They went from this really small thing that took forever to grow to exploding when they turned that corner, and I talk a lot about bamboo. A lot of people are like, certain species of bamboo grow like 7 feet in a year. And everybody's, oh, well, it's just kind of dormant. And then it grows. And that's actually not true. What happens is, in order to support all that amazing vertical growth, there's all this incredible root ball. This huge root ball is growing. So the growth rate of the Lyme field, or the growth rate of the, of the bamboo root system, is the same all the time. But it just, when the time is right, they've done the foundational work to support the huge change, then it sprouts and we see it.
So are you calling me a root ball and you're a sprout?
It's possible. I mean, I'm so glad to see that you're around to be, we were talking about our beloved friend, Ray Jones earlier. It's like, I would have, one of the things that breaks my heart, I mean, other than just not being able to hang out with my friend anymore in the physical form, is that he doesn't get to see the hard work that he's done. And I'm so glad that pioneers like you, who made my personal healing and the healing of so many people possible, but also now you're able to not only know all of that, but now together we're able to see this field change so much. Yeah. And to see that we're turning the corner or being the sprout, how amazing.
Yeah. See, it pays to be a root ball.
We need the root balls for sure. So anyway, just Dr. Joe Burrascano, thank you so much for everything you've done for the entire field and carving out this time, for all of us to learn about this amazing, sprouting that's happening, the corner we've turned. Because I think that, like, when I heard about it, I was like, this is a hell of a lot bigger than I think a lot of people think. Yeah. And I also know that one of the things that people ask me the most about is testing. And I try to explain testing. I don't know it as well as you do. Maybe I do now, but I'll tell you that is the most concise and also accurate explanation of why testing is so complicated and why you need to look at a company like IGeneX and look at people who are willing to go through that FDA clearing process over years and work together with the FDA to come up with because I know that if you talk to IGeneX and any of their representatives, I'm sure they'd say it was hard, but working with the FDA made us better and them better. Hey guys, Dr. Tom and Dr. Joe Burrascano back with you. We have just got off when we're done. We were talking a little bit more, and he went over a little bit about the number of bands on this blot, and maybe Joe, if you don't mind, just saying what you said to me really quickly, because I think that really will clarify it for people. And then the other part is the home AccuDart test is something that a lot of people will have access to. I get tons of questions about it. And, since you're the expert in this and know all about it, figured why not, roll another 5 or 10 minutes and really just make sure everybody gets, all the knowledge that you can share with us today.
Yeah. Sure, definitely. We're sprouting, you see.
Yeah, exactly. Yeah.
Well, we're talking about the immunoblot, the IgG immunoblot, the one that IGeneX just had FDA cleared. And I mentioned to Tom that it contains not, the usual CDC 10 bands, it has 31 bands. And what makes it really unique is, like, for example, band 23 is not one band 23 on the immunoblot. There's 9 of them. There are 9 31 bands, because this is for all the different species to cover. There are 2 different 41s, 2 different 39s, even 2 different controls. So when you call it positive, you have to have 2 from 2 different groups. Like, you can't have 2 bands 23. You have to have a band of 23 and a band from another group. But still, there are 31 bands on this immunoblot. And that's really what makes this so incredibly special, and why nothing else compares to it.
Yeah, and I think what's interesting and that I comment on was, I know we have the 10 in the typical Dearborn criteria ones, and IGeneX usually they'll report 12. So when you said 31, I was like, whoa! But they've got, like you said, 9 of the 23 you said now, but also 9 of the 31 or something. So very specific, and it's so when we're as clinicians or even patients seeing their results, there's 12. Some of those, the super important ones, based on all the feedback and the different species, are all lined up. So that, like, they're not just calling, like Dr. Joe just said, like 223s, ooh, bing, bing, bing. That's going to lead to your 23 being positive if one or multiple are positive. Right. So the thing that's important to realize is you're reading 12, but 31 different criteria go into those 12, essentially.
That's the background.
And yeah, amazing. And then the other part is so amazing, is, and as a clinician, I have to say, but people come to me for, like, the super most accurate thing, but not everybody has access to Tom or Joe or one of the other clinicians, like in our LDPC or whatever. So what's up with the AccuDart? Because a lot of people, it's getting a lot of press. A lot of people are interested in this. And it might be really important for people who, might not have access to a doctor, or are in an area, underserved areas and stuff. And there may be some other clinical applications that I don't even know at the moment. So I'm really excited to hear a little bit more detail about it.
Okay, so what is it? AccuDart is a home blood test kit for Lyme disease. How do you like that? And it's a kit you get from IGeneX, and it comes with a finger stick and a little pad. You stick your finger, put the drop of blood, and you mail it back to IGeneX. And you get it online. I don't know, the website is accudart.com or something. You can find that out from IGeneX. But you order the kit online, and you get the blood done, and you send it off to them. And the cool thing is, it's not an immunoblot, but it does use recombinant multi-species technology. Now, you get a yes or a no, and you don't get IgM or IgG. You just get a positive or a negative. But it's the same type of recombinant technology in this new FDA-approved immunoblot kit. So you're getting a high-quality test. Now, I think it's great. Let's say you're going to a physician or a clinician who takes care of Lyme, but he has a waiting list. Well, you can get the blood test done ahead of time. If you're between visits, you want to have an update, you can get the blood test done ahead of time. Let's say someone's clinically changing and say, you know what, I think we need to retest you. You can do it again. Someone who's been through treatment and doing well is starting to feel sick again. You can get the blood test done. And this one test combines IgM and IgG and all the different important bands of a multi-species immunoblot. So it's absolutely a fantastic thing to have.
So if I kind of, based on my research and looking at it and everything, I think it's AccuDartHealth.com if I'm on the right place, and I'm pretty sure I am.
Okay.
So with Lyme, you're going to get Lyme comboed, and they're not going to break out what species. They're not going to break out IgM or G, but they're going to say Lyme, yes or no. So someone would know they're exposed to Lyme.
Yep.
Yep. And then there's also a borreliosis and a babesiosis and a tick-borne relapsing fever version as well. And that you can buy separately, or you can buy a tick-borne disease test panel where, if I interpret this correctly, it would be Lyme, yes or no, Babesia, yes or no. Oh, there we go with the funny little reactions. Bartonella, yes or no, or and I don't know if I did tick-borne relapsing fever or not, because my reaction thing was freaking out, even though I turned it off. So, but that's really what we get. So it's not telling you kind of more likely recent or more likely in the past, or all the little specifics that like a Lyme literate physician would understand, but it's enough to say, hey, do I even need to go to a Lyme literate doctor and be on the waiting list potentially?
That's right. And then you get the immunoblot to really see what's going on, maybe get a fish or a culture to time the whole thing out, test the immune system that way. And so that, is another revolutionary thing. We talked about the tide being turning and the sprouts sprouting and all that, but this is all part of it.
And it brings up one other question I didn't even think I realized I had, but sometimes I'll use like the CEPCR for people, say, on things like intravenous gamma globulin or IVIG, because you could have some, getting antibodies from other people. But I just I don't know if you know the answer or if anyone's looked at it, but with the new recombinant technology and these immunoblots, do you know if those are kind of like less sort of susceptible to sort of like false positives if you're getting somebody else's antibodies? I mean, I'm assuming if you have antibody, you have antibody, but I don't know with that recombinant technology if that would even make testing while you're, right after you got IVIG, maybe something that could be still accurate as opposed to what it is with most testing.
Well, like everything else, it's not an easy answer. It's complicated. With the lower technology testing,
asking those questions.
You ask a question. Hey, we've got another 20 minutes. With the older technology, like an IFA, ELISA, and so forth, even a Western blot, after you've gotten IVIG, there's going to be cross-reactivity. It's known that those tests will cross-react with people who have high IgG levels from autoimmune disease, for example. So you can get a false positive on an old technology test just because it's gamma globulin there in large amounts. With the immunoblot, that won't happen just because it's gamma globulin there. But if the donors had Lyme and they had antibodies, it's sensitive enough that you could pick it up. So you're not going to get like a smear of antibody like you would on a Western blot where everything just lights up. But you might get a band here and there. So if you do an immunoblot on someone who just got IVIG and you're finding a positive on one of the bands or some of the bands, be suspicious, because someone had the tick-borne disease. Was your patient or the patient preceding that one who gave the blood? Now, is it likely? The answer is probably not, because it's pooled blood. They say one bag is 10,000 blood samples pooled together. So yes, Lyme is very prevalent. They say, 16% of the world population has been exposed. So it's a possibility, but I don't think it's that strong of a positive that you'd have to worry about it. But You're absolutely correct. If you have someone getting gamma globulin and they show positive on immunoblot, you're obligated to go further and do a direct test and even a T cell response assay, because that would not be confused by that.
Right. Well, and more testing that we didn't cover before.
Yeah.
Right. There's so many different tests out there. I mean, I think it's so helpful. Do you want to tackle T cells in like a couple minutes, or is that?
Yeah, I'll talk about it because that's
why not?
important.
I mean, now that we opened the can of worms, what the hell?
Well, I don't call it worms.
Yeah, right.
You scratch some worms. You're right back to nature. I can see that. So, T cell testing. It's an indirect test. Okay. So a B cell test is what? A serology. B cells make the antibodies, IgM, the IgG, IgA, whatever, and you measure that with the serology. That's an immunoblot, a Western blot, all that. But the other arm of the immune system can be tested too. Those are the T cells. When they're exposed to a pathogen, they activate to try and pack them in, engulf them up. And actually, the T cell response comes before the B cell. You can get a positive T cell within the first week of an infection. But the problem is the T cell response hands off to the Bs. So the T cell response assay starts to go negative even during the infection. But it becomes positive in late Lyme. When the B cells get exhausted, that goes the handover back to the T cells. So the T cell assay is very good in very early Lyme, and it's also very good in chronic Lyme. But the subtlety that I want to talk about, we talked about gamma globulin. Why is someone getting gamma globulin? Either because they're deficient or because they need really strong, immune modulation. If you have someone who you suspect has poor immune function, if you do a B cell-based serology, let's say an immunoblot, because that's the best one, that measures B cell response. But you also should do the T cell response assay. It's called the IgX spot, because now you have a picture of both arms of the immune system. If you have someone, for example, who's FISH positive or culture positive, but T cell negative and immunoblot negative, you know their immune system is compromised. So I like to recommend that you do both arms of the immune system, the B cell test, which is an immunoblot, and the T cell test, the IgX spot, not only in the beginning, but from time to time during the course of treatment, maybe every 3 months or so, because you get a better picture of what's happening to the immune system. If someone has a weak immune response on the immunoblot and you start to treat them successfully, the response actually increases as they free up bound antibody. And then with successful treatment, it starts to go down again. If it doesn't go down, or if you have persistently positive IgM that doesn't convert to IgG, that's a sign that the infection is not controlled. So it's very useful to do serial serologies. Now, people used to think, serology is past exposure. What's the point of doing it again? I know it's positive. It's not going to change. It does change, and it reflects how well your treatment is working. So that's the key here. You want to do serial testing, not every week or every month, maybe every 3 months or so, depending on the clinical situation, and include in that the T cell response assay, because you're going to see when the immune system starts to recover and heal.
Yeah, I think it's so important. And I was in the back of my mind just hearing like people like, oh, the costs. And I'm like, well, one, hopefully insurance will start to roll this in as more tests get cleared. But, I had someone who recently did the CEPCR because she is immunodeficient and on IVIG and a few other factors. And I didn't want to just do immunoblotting. So I decided, since we had done it in the past and we were kind of a little stuck in our treatment, it's always interesting where you pick these things up, Yeah. And so I did it, and she was Babesia positive on culture and the DNA, and it had never come up. But I was the first person in 3 years to even suggest this kid with a total IgG of like 350 at age 13 needed IVIG. I mean, this is like true, immune deficiency. And, it was really nice to be able to do the test and get it, because when I started the treatment, kind of like the patient you were referring to earlier, changed everything. Years. Yep. Yep. And I've had people, every once in a while we'll see a congenital Lyme case. But in this case, it's all congenital babesiosis. And what was beautiful was the baby wasn't really affected, and we were able to give treatment to prevent really bad problems, because congenital babesia of the other form is quite life-threatening. But mom had been treated by another provider prior to becoming pregnant and referring to me, and she had a rocky road where they hadn't diagnosed the babesiosis because they had never found it.
Yeah.
But now we have the new technologies, and hopefully you don't have to wait that long, and we can do a CE-PCR or one of these other technologies we talked about. Because sometimes you have to invest the money to make the change, and hopefully, we'll start to see more and more insurance coverage, so we have greater accessibility. Or we might use a thing like an AccuDart to, hey, maybe I don't have it completely slam dunked what it is, but when I'm stuck, I can do this for a lower price tag and at least know, hey, I've done the baseline and now by the way, I've had that. So hopefully everything we've talked about today, Joe, will be something that will give hope to someone, both the clinicians who are struggling to make sense of all these lab tests and these crazy overlapping symptoms, as well as patients who've been suffering. Because I just remember the first 6 years of my infection and illness, no one knew what was going on. They just told me it was in my head, and you start to believe them after a while, but then there's something in you that fights it. So I really feel like I appreciate your time so much, because not only does it give hope to me, and I know there's hope out there, but when we're sharing this kind of scientifically based hope for the community, that's really warms my heart. And I really want everyone else to feel that momentum and sprouting.
Well, the IGenics has a saying. They say that the most dangerous test is a false negative. Yep. True
story.
Yep.
Yeah, because I can make a clinical decision for sure pretty easily on a positive, and if I don't think it's correct, I know where to go with that. But missing it completely, and then not only just not considering it today, but putting it in sort of the in the filing cabinet or in the trash can and never looking at it again. That's essentially what happened to me. I had acute Lyme, got treated for 10 days, was sick for 8 years, and then it took 4.5 years to get better.
Yeah.
That's the nutshell. So anyway.
Yeah.
But if it wasn't for you and IGenics, I wouldn't be here today. Literally, I don't think I'd be alive. So I think
my work was worth it. See that?
Yes. Well, at Nick's, where we did that little, we had the little lunch where we, honored Nick Harris, who's created IGenics and worked with you, all of you guys, to really put this field in the map. I talk all the time. People who follow us know that I love talking. I'm very passionate about educating. I could barely speak because, like I just did to myself, I realized that if it wasn't for people like you and the early iLads people, or what became iLads, and people like Nick and IGenics, like I literally might not be on the planet right now. Yeah. And I know so many patients who have experienced that. So from the bottom of my heart, thank you so much for everything you've done, and especially what you shared with us today, because so many people would not have any hope at all if it weren't for people like you. So,
well, your story and the stories like that make it all worth it for me. And that's why I keep going.
Yeah. Well, so great that I'm so glad we turned the camera back on and added part 2. So again, everybody, Dr. Joe Burrascano, just the man, the myth, the legend, and clearly the root ball that has made all this sprouting possible. Thanks for joining us. I really appreciate you taking the time out to listen to us here on the Lyme Insider. We're always trying to give you that information that you need that can really change the course of your life and or your loved ones. And really, it's not, and to empower you, because we're giving you the science, right? It's not just, we thought this and try this. Like, I really want to ground all this, that there is science in your healing and to get in front of you. So thanks again for joining us.
Thank you all.